Hello, welcome. I'm Dr. Tony Malioco, the host of the Cancer Informant. Today's episode, I'm going to focus on discussing barriers to cancer care. Cancer care and treatment opportunities have been rapidly advancing over the last several decades to the point where there are many treatment opportunities and effective therapies to manage even advanced cancers. This is great news for those who can get access to these advances in treatment and therapeutics. However, for others, significant barriers still remain that impede their ability to get proper diagnosis and effective treatment. Let's begin and consider some of the barriers that a patient faces when confronting a diagnosis of cancer. Some of the first barriers are access to knowledge in terms of understanding risk of cancer and general health. We know if a patient has poor health or comorbidities, for example, diabetes or other illnesses, such as addiction or mental health issues, they may neglect their personal health, and this may put them at risk of developing cancer. In addition, certain addictions, such as cigarette smoking and tobacco use, can dramatically increase the risk of development of particular cancers, especially lung cancer, cancers of the pharynx, even cancers of the bladder, kidney, and other organs. Diabetes is another factor that can increase the risk of endometrial cancer, breast cancer, and colon cancer in both men and women. The use of alcohol can also increase the risk of many different cancers. Now, some of the barriers that patients face is access to screening programs. So some patients may live in areas where they don't have access to screening programs for early detection of colon cancer, lung, or breast cancers, and these patients may present with later disease. When a patient presents with a later stage disease, a stage 3 or 4 disease, the ability to cure these diseases is much diminished. And essentially, if a cancer is spread, the probability of a cure is very limited. The best chance for cure is to get cancer at an early treatable stage, which are typically stage 1 and 2 cancers, where the cancer can be easily surgically removed and any residual cells treated with either radiation or adjuvant therapy. When a cancer is more advanced, obviously this creates significant challenges for treatment. One of the additional barriers that a patient may face is navigating the system. When a patient is seen by a generalist, there's a risk with their diagnosis of cancer in that they may not have a proper specialist who is skilled at diagnosing their cancer and managing and treating their cancer. This can be particularly problematic in remote areas or community-based areas where specialists may not be readily available. One of the first issues confronting a patient is the accuracy of their diagnosis. Typically, a cancer diagnosis is made first radiologically, where something is found, and then surgically, where a piece of tissue is removed and then sent to a pathologist. Now, while most pathologists are well trained, not all of them are experts in cancer, and this can leave issues in the diagnosis. I've seen many cases of patients who have had a presumed diagnosis of cancer, when on careful examination, it was determined that the lesion was not actually cancer at all, but some other sort of unusual reactive benign condition or another lesion that was actually benign. In some instances, there may even be issues where a specimen may be mixed up or damaged, leading to an incorrect diagnosis. So clearly having an accurate and complete initial diagnosis is very important. And I think all patients should really think about that and confirm that their diagnosis is actually accurate and complete. Some patients are reluctant to consider second opinions. They feel that their care doctor may feel threatened by this. I would advise a patient that this should not be an issue, that a physician who is treating the patient will actually feel better if the diagnosis is actually confirmed and that it's clear that the diagnosis is accurate and complete. Therefore, a proper treatment plan can be initiated. If it is discovered that there's an error in the diagnosis partway through the treatment, this can obviously create challenges in managing the patient from this point on. It is really imperative that an accurate diagnosis is made at the beginning. In addition, patients are often faced with many choices because now there are so many therapeutic options that there may be choices that involve surgery, radiation, different types of chemotherapy, chemotherapy, targeted therapies, and so on. And it can be very confusing for a patient. Now, if a patient is in a community center or a remote area, they may be working with a generalist who may not have expertise for management of their particular cancer. In those situations, again, it can be helpful for a patient to seek additional second opinions or even third or fourth opinions so that there's a degree of confidence that the lesion has been correctly diagnosed and that a reasonable treatment plan has been put in place. So this is obviously important for proper planning. Now, other barriers that a patient may encounter is coverage of advanced diagnostics. There's a huge issue, particularly for patients who are in private insurance plans, where when additional treatments or diagnostic services are required, that some of the diagnostic services are not considered to be standard or might be considered to be somewhat research. In these instances, a insurance company may not cover a certain diagnostic or not approve a treatment. This is a huge problem for patients where these treatment opportunities are actually evidence-based and where these new diagnostic services have been properly vetted. In these cases, there may be opportunities to appeal to the insurance company that they reconsider a decision so that appropriate diagnostics and treatment opportunities are made available. I think this is a significant problem, and patients need to be more aware of it in terms of the challenges that are faced by diagnostic service providers and physicians who are trying to treat patients when dealing with a private insurance industry that can be very cumbersome and difficult to navigate. I believe there needs to be a significant amount of work done to enable this process to become more transparent, evidence-based, and effective. This may involve also use of foundations or societies that are patient-driven. Patients, I always tell them that companies and politicians are particularly responsive to the needs of patients, particularly when they are organized in advocacy groups and in groups that try to raise awareness. So if you are that way inclined, I would encourage you to seek support of your local foundation or society for patient support in cancer care. Now, there are also challenges with use of complementary therapies or non-conventional therapies in that the medical system may be resistant to considering these types of therapies. Now, from the point of view of a physician, physicians are trained to really think about treatments as being evidence-based or non-evidence-based. And in typical medical practice, treatments that have a proven effectiveness and safety are those that are recommended to be utilized. When there are emerging therapies of uncertain benefit, a physician is put in a position where there's a lack of knowledge to consider whether a treatment might be helpful, because in some instances, a treatment might actually be harmful or cause unexpected side effects. In treatments that are unproven, it can be challenging to understand how to incorporate those into a treatment plan, and can be very confusing for a physician to consider those types of unproven treatments. Now, an area that is of particularly valuable is the use of clinical trials. And when I talk to patients, I strongly encourage the consideration of clinical trials, that clinical trials can be very effective. Often it allows access to early agents that have been proven in preclinical studies. And usually these agents are combined with standard therapy. Another important reason to consider a clinical trial is that the cost of the treatment may actually be covered, so that some of these experimental treatments would be out of range of treatment or not currently available. A patient may get access to them through a clinical trial, which allows them to gain access to very effective therapies. I like to point out a prominent case. Jimmy Carter, who was a president of the United States, developed metastatic melanoma that involved his brain many years ago. And more than 20 years ago, a patient with metastatic melanoma would not be expected to survive more than a month or two. But Jimmy Carter was on a special study where he obtained access to immune therapy, which ended up really putting him into a complete remission that is sustainable for many, many years, actually more than 10 or 15 years, I believe he's been in remission with that. So through use of a clinical trial, you can get effective treatment that can be extremely durable and very dramatic in response. That's something that I would definitely encourage a patient to consider. Another point when considering treatment opportunities is not to wait until it's too late, because when a patient is healthy and they want to try a new treatment, there are a lot of support to enable that. If a tumor progresses to a point where there's significant side effects or impact on the health of a patient may become ineligible to enroll on a clinical trial. well. So it's important that a patient consider their treatment opportunities while they're still in relative good health. Now, the best way to do that is to ensure that they do actually have that correct diagnosis in terms of the pathology being correct. Also, that it's ideal if they work with a lab that can digitize a sample or create electronic record for the patient so that the information is portable. And if they want to seek treatment at a different medical center, that the information can be easily shared with another medical center where they might go to enroll on a trial that may be limited. In addition, I'm a very, very strong advocate of molecular analysis, even in early stage patients, in that a molecular analysis of the tumor can give you a very comprehensive analysis of actionable mutations, not only for immediate treatment, first-line treatment, but it can also give you information on second, third, and fourth-line treatment as well. For example, a patient with a breast cancer might have an initial assessment where the tumor shows to be HER2 positive and ER positive, and they might be eligible for an anti-estrogen or an anti-HER2 agent, but they might have other mutations that show that there are fusions present or other genes amplified, or even presence of things like a BRCA mutation that can be utilized to plan additional therapies in the second, third, and fourth line setting. Also, a patient should be aware that their tissue is generally always available, so that if you have had a diagnosis of a cancer, your biopsy specimen will be maintained at a hospital or a pathology lab for at least 10 years and could even be maintained for a longer period of time. And you can actually go back to use that specimen for additional molecular analysis with modern treatments and current assessment tools. Even if your diagnosis was made a significant time ago, the specimen may still be available. Now, if the specimen is not available, that doesn't mean that you're at the end of the rope. You can still utilize liquid biopsies, and liquid biopsies have become particularly more powerful in the last few years. And some advances allow us to really do very comprehensive assessments of these blood tests. In the blood, you can isolate circulating tumor cells. The importance of a circulating tumor cell is that we can really evaluate what sort of protein is on it. And this has become more important in the past year as to whether these cells have targets on them, for example, HER2, in that there are now new antibody conjugates where there are treatments available for cancers that are metastatic, that are even in the HER2 low expression categories. Getting these circulating tumor cells can let us identify new targets and new clinical trials that might be of value to a patient with metastatic disease. Also, in a blood sample, you can measure cell-free DNA, and a tumor may evolve over time. So initially, it may be tumor mutationally burden stable, but over time, it may have acquired additional mutations that can now be targeted with specific therapies or even an immune therapy. So a liquid biopsy can always be extremely helpful, particularly in patients with advanced disease, because typically there will be cell-free DNA in the blood, and that DNA can be easily measured to determine if there are actionable targets. In addition, the use of that DNA can be useful to monitor if a patient is responding to treatment or not. By taking sequential sampling, one can determine if a patient goes on to a treatment, if the mutations in the blood go away or if they increase. This can give an indication that a therapy is working or if a therapy is beginning to fail and whether an alternate therapy should be considered. And as I mentioned, it's always best for therapies to be adjusted while a patient is still well, in good health, and who can tolerate new types of therapies and so on. Because if a patient does progress to become less functional, then they may no longer be eligible for clinical trials or for certain therapies that they may not be able to stand the side effects or toxicity of these therapies. Planning is extremely important when one does have a cancer, and getting a complete profile is important. I should also point out that not all molecular tests are the same. So when you are considering a molecular test, it's important to look at how sensitive is that test? Is that test actually identifying actionability mutations that can be linked to therapy in terms of a companion diagnostic? That can be more important than just monitoring whether a cancer is present or not. So actually getting a readout as to whether there are targets that can respond to a particular new therapy can have high value for a patient. So I would say when you're looking at potential molecular classification, remember, not all tests are the same. There's significant variation in the quality of the test and in the information that you can get. And I would strongly advise you speak to a molecular pathology expert in terms of what is the right test for your condition so that you can properly select the right test and be certain that the information you get is of high value to you. and that can also be utilized by your oncologist so that they can properly treat you. And again, some companies and some centers are moving towards multidisciplinary care. And I strongly recommend multidisciplinary care because cancer is best treated by combination of care. And by combination, I mean use of surgery, use of radiation, use of chemo, targeted therapies, and immune therapy. To be able to get this comprehensive approach, a patient actually needs access to multiple experts. If the patient is in a remote area, multiple experts can be brought together utilizing things such as virtual tumor boards or other sorts of telemedicine approaches where a case might be shared and experts can come in from outside to give advice on how best to treat a case. Again, strongly recommend second opinions and multidisciplinary care for the best possible outcomes for treatment of cancer. Finally, always consider clinical trials. Clinical trials can be very effective. Some patients are worried about them in that I don't want to be a guinea pig, I don't want to get an experimental treatment, or I may be denied a standard therapy. This is not the case. The vast majority of clinical trials have been very carefully constructed by teams of experts. They've been vetted by IRBs, which are institutional review boards that really ensure that the trials are safe. Many of them are overseen by the FDA. There's high data integrity, that the trials are safe, that the people conducting the trials are not biased, that they're often blinded, meaning that the person conducting the trial doesn't actually know if a patient is on the investigational arm or the non-investigational arm. And in this way, the data from the trial is very high quality and can also give indications about effectiveness or not. Also, trials are continuously monitored when in progress for safety. And so a trial will be stopped if it appears that an agent is unsafe. Also, a trial will be stopped if it appears that an agent is extremely effective. And for that reason, a trial will be stopped so that all of the patients on the trial can actually go on to the effective agent. And in many trials now, in modern trial design, it's something called a crossover design, which means that at some point in the trial, there'll be a crossover so that if a patient progresses and they happen to be on the control arm, they'll actually cross over to the experimental arm and be given the experimental treatments as well. I think we're living in a very interesting time of precision and personalized medicine, where there are actually over 9,000 trials are currently open for patients with cancer. So there are many trials available. Often it's surprising that the physicians are unaware of the trials, and many patients get benefit by exploring trials on their own and identifying trials, working with other experts in terms of cancer navigators, or taking on themselves to go to other experts that they can consult with privately or separately to determine if there are treatment options out there that might be suitable for them. And like I say, a patient's primary care provider should not be concerned if a patient is trying to get additional information about new treatment opportunities or alternative treatments or so on, that a high-quality provider will be open to discussing these aspects with the patient. And if a patient does bring innovative ideas about new trials or new therapies, a high-quality provider may consider those and think those could be of value, unless there's clear evidence that there's some reason that those should not be embarked on or that they may actually be harmful to the patients. A patient definitely needs to have trust in their care provider to ensure that that person is giving them the best possible guidance and therapies for their cancer treatment. I hope that this discussion was useful. We reviewed some of the barriers and concerns facing cancer patients today. In review, one of them is that cancer treatments are changing very, very quickly, and that patients who are being treated in rural or community centers may not have access to the very latest therapies, and they may need to consider second or third opinions if they want to look for alternative treatments or get access to clinical trials. So that's always an important consideration for a patient. Are they absolutely getting access to the current therapies, the best evidence-based therapies, and access to clinical trials? Also, there are many barriers in the system, particularly access to high-quality testing, that some insurance companies may put barriers in place that restrict a patient's ability to get access to testing that could be very beneficial. This is a point of concern for me, and an area where there needs to be further advocacy so that the advances that are rapidly being made in research can be quickly translated into patient care and be made available to patients, not only in academic medical centers, but patients across the country being treated in community and remote areas as well. So this is one of the areas I feel a lot of work needs to be done. And particularly in this cancer year, it's been identified that there are significant cancer gaps and that there are marginalized populations of patients, for example, African Americans, people who are low socioeconomic class, who are struggling with health literacy, who do not have access to the best possible care, and as a consequence are suffering that they get suboptimal care, they get side effects, and they may not get appropriate treatments and may suffer worse outcomes as a consequence. So there's significant work to be done to close the gaps. Thank you for tuning into the podcast today. I'm Tony Malioco, and I'm the Cancer Informant. Please visit our website to listen to other podcasts, also to leave comments and leave questions. We can address those in future episodes. I appreciate your viewership and listening to our podcast. Have a wonderful day. Keep safe. Take care. Bye-bye.